You need to check your vision immediately if you have been diagnosed with high cholesterol. Recent medical evidence shows a frightening link between vascular disease, fatty deposits, and sudden retinal artery occlusion. If you wait for symptoms to appear, it might already be too late to save your sight. This is not about blurry vision after staring at a screen. This is about blood flow. Your eye is not only a camera, it is living nervous tissue. The retina at the back of the eye needs a constant supply of oxygen through tiny arteries. When that supply is blocked, part of the retina can begin to fail within minutes. One of the warning signs is called Amaurosis Fugax. Many patients describe it as a dark curtain, a shade, or a gray shadow coming down over one eye. It can last seconds or minutes and then disappear. That is why it is dangerous. Because when vision comes back, people often ignore it. But a temporary blackout in one eye can be a vascular warning sign. It can mean that a small embolus briefly blocked blood flow to the retina, then moved or dissolved. The next blockage may not be temporary. To understand why cholesterol matters, start in the carotid arteries. These are major blood vessels in the neck that carry blood toward the brain and the eyes. Over time, high LDL cholesterol can enter the artery wall, trigger inflammation, and contribute to atherosclerotic plaque. That plaque is not just fat sitting in a pipe. It can become inflamed, fibrous, calcified, and irregular. Pieces of cholesterol-rich or calcified material can break away from the carotid artery or from the heart and travel through the bloodstream. If that fragment reaches the retinal circulation, the eye may become the place where the vascular system reveals its failure. A small embolus can block a branch retinal artery. A larger or badly placed embolus can block the central retinal artery. That is the main artery feeding the inner retina. When it closes, oxygen delivery stops. Photoreceptors and retinal nerve cells are highly sensitive to oxygen deprivation. Unlike skin or muscle, retinal tissue does not tolerate long interruptions in blood flow. That is why central retinal artery occlusion is often called an eye stroke. The symptom is usually sudden, painless vision loss in one eye, just a rapid loss of vision. There is an important distinction here. A temporary blur, dimming, or curtain-like episode may be a warning event. A full retinal artery occlusion can cause permanent retinal injury. Once the retinal tissue has been deprived of oxygen long enough, treatment becomes much less effective. The problem is no longer just a blocked vessel. It becomes dead or severely damaged neural tissue. This is why emergency timing matters. In acute retinal artery occlusion, the goal is to restore oxygen and blood flow as quickly as possible. Some centers may consider urgent stroke evaluation, hyperbaric oxygen, or thrombolytic treatment in selected cases and within strict time windows. But the evidence is not simple. Modern guidelines still emphasize that after the acute phase, there is no proven treatment that reliably reverses vision loss from central retinal artery occlusion. That is why this condition is treated as an emergency, not because doctors can always reverse it, but because the only chance is early. Recent 2026 data reinforced this point. In a large matched cohort study from London, patients with central retinal artery occlusion had a nearly threefold higher risk of later ischemic stroke or heart attack compared with matched controls. So an eye stroke is not only an eye problem, it can be a cardiovascular warning signal. Now, cholesterol does not always announce itself with symptoms. Many people with high cholesterol feel completely normal, but sometimes the body leaves external clues. One is arcus senilis, a white, gray, or bluish ring around the cornea. In older adults, it can be common and not necessarily dangerous by itself. But when it appears in younger people, especially under about 45, it can raise suspicion for inherited lipid disorders such as familial hypercholesterolemia. There is also a deeper layer. The retina itself can show vascular disease. Retinal findings in people without diabetes have been linked with systemic hypertension, carotid atherosclerotic disease, retinal vein occlusion, and cardiovascular risk. Clinical reviews have also noted links between retinal microvascular abnormalities and carotid plaques, carotid artery thickness, and higher serum total cholesterol. This is why eye exams are not just about glasses. The retina is one of the only places where doctors can directly see small blood vessels without cutting into the body. So what actually prevents cholesterol-related vision loss? Not eye drops, not supplements, not waiting until vision changes. The strategy is vascular prevention. First, know your numbers. LDL cholesterol, non-HDL cholesterol, triglycerides, blood pressure, A1C, and family history all matter. Second, lower the risk at the artery wall. For many people, this starts with diet quality, physical activity, weight control, not smoking, and treating high blood pressure or diabetes. But for people at high cardiovascular risk, lifestyle alone may not be enough. Third, do not ignore one eye symptoms. If you suddenly lose vision in one eye, or if a dark curtain covers one eye and then clears, treat it as an emergency. The useful rule is this: temporary vision loss in one eye can be the rehearsal. Permanent retinal artery occlusion can be the event. And if cholesterol is part of the reason your arteries are unstable, your first symptom may not be chest pain.